You know, it's the conclusion of National Heart Month. I wish it was National Heart Day every day. I wish we would consider looking at our bodies and our lives and our health every single day, from a heart standpoint to a nutrition standpoint to an exercise standpoint. We should make this a part of our lives that, just like you get up in the morning, you brush your teeth. I think it's so important that we look at our heart health every single day. We're going to be showing you some videos, so eat up real quick because I don't want anybody to lose their appetite. We're going to go from animation to real life stuff. So, we do have some bags that we collected from Delta Airlines if you need them. No, I'm just joking about that. But we are going to have a test at the end of this session, just like Dr. DeBakey would have done to me. I was privileged and honored, really. I realize it now how lucky I was to have trained in Houston under two of the greatest heart surgeons this world has ever seen. Dr. DeBakey, who was as brilliant a man as I've ever seen, who probably was also the meanest man that I've ever met. I still have scars to prove if you want to see this later. And Dr. Cooley, who technically was probably the finest surgeon I've ever seen. I try to model my life after those two, except for the anger that Dr. DeBakey had. But as I said, those two were the most innovative surgeons that I've ever met. And every day I bless them because of the training that they did for me and my cohorts. After I finished up in 1991, I finished my residency training and fellowship at that time. And really, everything that I did for the next 10 years was very similar. Technology did not change. Every open heart surgery case that was being done in this country was being done the same way, basically. Every vascular case was being done the same way. Every thoracic or lung or esophageal case was being done the same way. There was really no innovation, and all of a sudden, around the year 2000, this technology has just exploded. I'm sure you've heard a lot about it in the press, and you know, our patients, I think, are even getting much more attuned to what's going on. And I actually now have patients ask me what to do, and they tell me what they prefer that I do with regard to a vascular case or an open heart surgery case. So we've moved from valve surgery, where everything was being replaced, to valve surgery, where most of the cases now we're actually repairing the valves. We've done big incisions before, and now we're doing smaller incisions. We're doing, instead of doing on-pump surgery, oftentimes, and most of the time now, I'm doing beating heart cases. And we have an example of this afterwards. We're allowing the heart to beat, which is so much safer. And in this patient population, for example, in this room right here, most of the folks in this room, I would not want to put you on the heart-lung machine and arrest the heart, but allow your heart to beat the whole time so that it would be such a much safer operation. The vascular surgeries that we're doing, before we would make big incisions, and now we're making small incisions. And a lot of the surgery that we're doing is based off of a catheter. So that's called catheter-based intervention. And so much of the repairing that we could do for vascular surgery these days is being done in the cath lab, or in what we have upstairs, which we've been blessed with here in Lufkin, is a beautiful hybrid operating room, which allows us to do catheter-based intervention and even open type of surgery cases. So technology has driven my specialty in the past 12 years. And the interesting thing is I finished up in 1991, and I've really had to stay attuned with all these advances that have occurred. So I've got to constantly be going away to courses and to training classes in order to stay abreast, because the technology, as I said, is changing. You know, you may have heard a lot in the press lately about these new valves that are being placed through the groin. Those are called TAVI procedures, T-A-V-I. You're going to be hearing a lot more about it. The FDA just approved it. There's been probably about 2,000 cases worldwide that have been done now, mostly in Europe. There's going to be a few centers in this country that are going to be doing it to do the initial trial runs on these very sick patients who would not tolerate open heart surgery like we've done in the past, where they will be going through a procedure where there's a small incision made in the groin, And the valve is actually advanced over a delivery tool, or it looks like a stick, that actually places the valve where it needs to go in the heart. And it's all done looking at a screen instead of looking inside the patient's body at the heart itself. So you're going to have to be paying attention to this because some of you may need valve surgery in the future. These are the things that we're going to talk about in my office or whoever doctor's office you're in. So, you'll be hearing even about new technology, even in medication, let's say. There's new advances for blood thinning. And I'm curious to see in the next 5 years, all these drugs that are coming out to replace aspirin and Plavix and Coumadin that have been on the market. And the patients need to know about this because for a lot of these medications, there is no antidote yet. So you've got to ask your doctor a lot of questions before he puts you on these. For example, if you're on one of these drugs that's a powerful anticoagulant and you get involved in a car wreck, what's going to happen to you if there's no way to reverse that drug? So these are the things that you're going to have to ask your doctor before they put you on these drugs. There are antidotes for Coumadin and for aspirin and for Plavix. So I'm going to be very curious to see what happens over the next couple of years when these drugs come on the market and what we're going to do to reverse those drugs. If one of you are on those drugs and you need open heart surgery on an emergent basis, how are we going to be able to achieve that perfect operation with you not bleeding to death on the table? So these new technologies I love because the patients are happier, they're going home sooner, their incisions are smaller, we have less complications than ever before. I mean, when I was going through my residency training program, we were looking at a 5% mortality rate for open heart surgery. Now it's less than 2%. And I look at open heart surgery like the airline industry. I don't want to see any mortality. If the airline industry had a 1 or 2% mortality rate, let's say, can you imagine how many plane crashes there would be every single day? So what I would envision in the future is that there be no mortality for any type of open heart surgery. And that's what's been going on for the past couple of years. So as you've seen, your family members and maybe some of you, the length of stays in the hospital are so much shorter. The need for blood transfusions are so much shorter. I try to look at every patient like a Jehovah's Witness type of patient. I don't want to transfuse that patient. I'll do everything I can. And there's some new technologies out there that prevent us from giving transfusions. As I said, with what we can do in surgery, we can limit the risk of stroke, of kidney issues, of blood transfusions, of heart attacks on the table, if we could do these things and do them safely. So I spoke about the valves. The valves that are going to be placed in the future, I think, are going to be more in the way of pig valves and cow valves. And I think you'll be seeing a lot more in the future, as I said, about these minimally invasive valves that will be placed. The success rate has been pretty good. It's not great. There's still a lot of complications associated with it, but you'll see that the technology is changing. And just like when all these new technologies come out, there's a high risk of complications. And then with the operators learning how to do these better, that there's going to be much less in the way of complications. And another thing I wanted to talk to you about today was the treatment of aneurysms. Now, up until about 5 years ago, whenever we took care of a patient with an aneurysm is a weakening of the wall of any artery, but typically the aorta. And 80+% of the time, it's below the level of the kidney arteries in the belly itself. I have never seen so many aneurysms since Shelley and I moved here in September. It seems like every week at this little institution, we're doing more than they're doing even in Houston, because the reps are coming out saying, we can't believe how many that we're seeing. And in fact, Shelley and I were at a Lufkin football game, and there was a fellow a few rows in front of us that stood up. Some of you may remember this. He stood up and he collapsed. And that man, I told my family at that time, I said, that man is either having a ruptured aneurysm or he has a heart attack going on right now. And a few hours later, I was called into the hospital to help take care of that man. Here we have aneurysms in the old days, and I mean old days like 5 years ago, which seems like the old days to me. because the way it was 5 years ago, it's so different right now, which I love, because I love this new technology. And as my wife knows, as Becky knows, I love to live forever just to see the way all of this technology is moving and making it safer to operate. And then I look at like Star Trek when I was a kid, and I would watch it, and they would do surgery without even making incisions. And that's probably where we're going one of these days, is we're going to have this type of technology. So here we go from major incisions in the chest going down to the abdomen, or just in the abdomen, and now we're just doing this type of surgery where we're making a poke hole in the groin, and we're running a stent up into the aneurysm itself. So instead of taking out the aneurysm, we're putting almost like a Band-Aid inside the aneurysm so that it doesn't see any more pressure. And so the stent sits inside, I'm going to lose that. The stent sits inside the aorta. And so the aortic aneurysm part doesn't see any pressure, and it just begins to shrink down at that time. So this is what the stent looks like. You'll see a beautiful animation of this very shortly. This has been just an absolute incredible invention for surgeons and for patients, because as Becky has seen in the past couple of weeks, we have taken care of patients who have been so sick and much older than anybody in this room, who have been either ruptured or in the near rupture state. Patients who have been turned down at many other institutions. We had a fellow who had a ruptured aneurysm turned down from Houston that we had to take to surgery. This man would have died just a few years ago. And now we have this technology that we were able to do this operation in about 30 minutes. And we saved that man's life, who had a huge dissection, rupture of his aneurysm that the cardiologist, Dr. Feld, and I took care of in the hybrid operating room. And he goes home in 2 days. Just an amazing thing to see. Do you have some more of my toys? Do you have some more of my stuff to show? Oh. My toys. So that's aneurysm surgery. That has completely changed. I haven't done an open aneurysm repair in about 3 years now. And so since I moved here, we've taken care of probably over 50 patients. And all of these patients have been treated in this way. So with regard to the open heart surgery, as I said, most of the patients that we're doing these days for bypass surgery, we're allowing the heart to beat the whole time. And we actually have a live demonstration of this. Not live, I shouldn't say live. We actually have a movie of this. Unless we have any volunteers, anybody having chest pain after those cookies back there? Sorry about that. So the beating heart surgery, again, has allowed us to decrease the mortality, the length of stay, the need for blood transfusions, kidney issues, and stroke issues after open heart surgery. And I love it. I love to see it. It's changed the way I think about a patient now that I take to surgery for bypass. In the old days, just a few years ago, it was like you go on the heart-lung machine, you stop the heart, you work on the heart for about 30 to 45 minutes or so, then you have to get the heart going again, and then you've got to disconnect all these tubes and lines from the patients. To me, it was very cumbersome. And now I think about these patients more like a vascular patient, which to me is a much more straightforward type of procedure to do. We do limited incisions in the chest. We do limited incisions in the leg to take out the vein. I'm sure some of you have family members who have had these long fillet incisions in the legs. Maybe some of you have had it. That would drive me crazy, because so many of our patients are diabetics. And if you give a diabetic a long incision like that, they're going to have wound healing issues. And the way I think about surgery is to always limit the amount of wounds in that patient, because that wound burden that surgeons give to a patient, they have to overcome. They have to have enough nutrition to heal up. They have to have the good body habits to heal up from that. They have to have basically a non-diabetic state. So we have to really keep the diabetics under very good glucose control, limit those incisions. And now we just make a little poke hole. And so for the past 10 years or so, I've been using a scope to actually go up into the leg. And we could simply harvest the vein in maybe about 10 or 15 minutes instead of making a long incision when the closure of that leg would take about 30 minutes. So it's so much safer. And when Becky and I are in the clinic now, I'll ask the patients, can I see your leg incision? And they go, no, it looks great. Don't worry about it. That's what I love to see. So we spoke about that. We spoke about the vascular surgery where we're making small incisions using this catheter-based technology, which the cardiologists have been using for a long time. So as surgeons, we've had to embrace that, and we've had to embrace working with the cardiologists on these patients almost every single day to get the patients through some of these very difficult procedures. And sometimes it's very complex. And as I said before, we've been blessed here at Memorial with this magnificent hybrid operating room that I would put up against anything that I've seen in Houston or anywhere around. And it allows us to take care of patients in that one room and do everything at the same time with the cardiologist. And it's so much safer for the patient because you're limiting the amount of anesthesia, the amount of trauma to each one of those patients. We've also started doing a lot of vein surgery. And I'm sure you all have seen or heard, have had some family members or yourselves have vein stripping in the past. Vein stripping, when I went through my residency, was my least favorite operation of all. It was my least favorite thing. We saw so many patients with varicose veins, painful dilated veins in the leg. They had pain, they had swelling, they had difficulty walking, they were miserable. So we would make many small incisions in the leg. We would actually use these hooks to actually hook onto the vein and pull them out. There'd be a lot of bleeding, and the patients have blood loss and scarring, and they have a lot of blood loss inside the leg, which would yield to black and blue legs, which I hated to see. And they were still miserable afterwards because the healing process was so long. And actually, Melissa is my Vanna White today, and she is going to start this up. Thank you. So now, for these veins, we're making a poke hole in the leg. We run a catheter up. That catheter heats up to about 120 degrees centigrade. This is radio frequency, it's not laser. I'm not crazy about the laser. This is much safer and much less temperature. So we take care of each section. Each section is 7 centimeters long. It heats up for 20 seconds. That section of the vein will shrink down, and it'll become like a guitar string. There's no more blood flow. The blood flow is diverted to, we have hundreds of veins in the legs. The blood flow is diverted to much more healthy veins in the deeper part of the leg without the valves. So as we get older, all of our valves begin to break down because we're upright creatures. We're the only creatures in the world that have vein issues. And we have those vein issues because we're standing upright, we're using our hands, and that's what's exploded our brain, and we could talk about that at length. But by standing up, it's caused us to have problems with regard to birthing of the children, for example, and with vein issues. So I see so many patients like you all in this room with vein issues. They have dilated veins, they have painful legs, especially at night, and they have swelling. And as it progresses, you go from pain, swelling, then you have skin color changes, ulcerations, the skin begins to break down. And then we even see patients that have what's called elephantiasis. It's like their veins look like the hide of an elephant. Elephants and giraffes, by the way, don't have these issues because they were developed that way. So that's the vein surgery. It's called radiofrequency ablation. It has been an amazing thing where I can take a patient to surgery, and the surgery I usually do on Friday. We turn on some nice music. We relax in the operating room. Takes about 10 or 15 minutes to do. We bring the patients in the morning. They go home that morning. They're back at work the next day. Or if I do it on Friday, they usually are back at work on Monday. Oh, don't show that. We haven't digested our food yet, have we? No. We still need about 10 more minutes. But that was not me. I am much more gentle. But basically, it's a needle in the vein, run up the wire. The wire heats up. It's, I hate to say brainless, but it's very simple. It's simple for the surgeon, simple for the patient. We're going to go through, that aneurysm surgery real quick. It's a really neat animation. Yeah. So this is an animation about how we fix aortic aneurysms. Yeah. This is the company. The company is G-O-R-E. They're based here in Arizona. You may have heard of Gore-Tex material. This is the same company. So again, to remind you, this is the graft that's placed on a stick. We gain access in the groin arteries just through a needle stick or a small incision. We advance it. We're watching a screen. We know exactly where to place it because of all of our measurements that we've done before. Again, it's the Gore company. Just a fantastic company that has supported surgeons all throughout the years. This is what we do in the hybrid operating room. The aneurysm is sitting right about at the belly button level. That's where it is about 85% of the time. Run up the catheter. There's just a cord that we pull at that time where we want to deploy it. We have to come up the other side. We have to still come up the other side. So it's a little slow today. But that takes care of the right side. And hopefully it'll show the left side. What would happen next is that we would take a little piece of graft about that long, and we would feed it up the left side and put it right there. So the graft would come up, place it right in there over a wire. That typically takes about 30 minutes to do. The open case would take 3 to 5 hours to do. Let's try it one more time. Because the neat thing is we just did this the other day in a patient who, 80 years old, 7-centimeter aneurysm, which is way beyond the danger point. 5 centimeters is where I begin to worry. At 5 centimeters, it just becomes exponential as to how that aneurysm wants to rupture. It's just like a balloon if you think about it. The more you blow up a balloon, the thinner it gets, and the more likely it's going to rupture. Let's try that one more time. Patient, I've never had a patient this young have this procedure. Usually they're much older. Again, the aneurysm is by the belly button. It's just waiting to get larger and either dissect, split, or rupture. We apply. Let's see if it works this time. And it is not going to work. But again, what would happen is we would feed up the other limb on the left side, feed it right into that open spot in the graft called a gate. We would do that through a wire. Let's go to the next one. And it takes about an hour or so in the hybrid operating room. We do this with the patients awake under epidural anesthesia, like the pregnant women get when they deliver. I can talk to the patients during the days. They could watch it on the screen, which is kind of frightening to me. Thank God we don't have any mistakes. So, the last one I'm going to show you. Yes, ma'am. We can knock you out. No, some of the patients we do put to sleep. When you have yours done, we will put you to sleep. All right. I will remember. What's your name again?
Sandra Gray.
Sandra. Write down Sandra's name. All right. Let's see. I'm 53. I'm going to retire in about 12 years, so think about this in the next 12 years.
Well, I've been retired first.
Okay. I think it's number 15. This is a friend of mine out of New York. He's at Staten Island, and he's a really good surgeon who loves to do these cases, these beating heart cases like I do. We went through a very similar training. And is everybody okay with this?
I am. Don't bother me. Don't bother me.
This fellow and I love to do the same thing. Dr. DeBakey would have thought that we were crazy. If he was here right now, he would be thinking, this is just crazy. But he never did this because the technology didn't exist. This is a small incision that's made just below the breast. So it's an incision that goes across. It doesn't go up and down. Place a retractor in the wound. Just open it up a little bit. Under direct vision, the artery that needs to be bypassed is sitting right there. It's called the LAD, the left anterior descending. And that's the artery in front. If you can imagine, there's three big arteries on top of the heart. The one on the right side, the one on the left side, the one in front. This is the artery in front, the LAD. These are some of the stabilizer bars that we have. And what happens is the heart will beat, but we stabilize the part of the heart that we're going to be operating on. This has suction cups on it, so it sucks down to the heart, and we stabilize it. We can actually screw it down. And it's a very rigid structure. And you'll see he's having a little bit of trouble doing this right now. But he's going to get it stabilized. Then he's going to make an incision in the artery to open it up just a little bit, a few millimeters. And there's a graft that he's going to bring down, the one from the inside the chest, called the internal mammary artery. There's one on the right side, one on the left side. And I still, to this day, feel that God put it there for heart surgeons. Because those arteries are the best thing we have for bypass purposes. So if you come into my office, I'm going to try to use arteries at any time I can to bypass. Because those arteries are so much better than using veins if we could get away with it. So he stabilized the artery. And it's really a simple operation at this point. He's just using a blade right here. There's a little bit of fatty tissue. The yellow stuff is fat. And so he's using a blade to separate the fat off of the artery. We know where it is when you open up the chest. This is a blower device. It just blows a little stream of air and a little bit of saline. That's the graft from the inside of the chest, called the internal mammary artery. He is having trouble stabilizing it. That's not me again. That's Dr. McGinn in Staten Island. That's not me. That's that fellow up there. No, but he's a very good surgeon. And we're wearing glasses with magnification. So I usually magnify by 2.5 or 3.5 times. And I'm wearing a headlight, so I can see in these little holes. And I can see exactly what's going on. So we don't have to make big incisions. This is a tape right there to prevent blood flow from interrupting the field. So he's just sizing and measuring the artery. He's going to cut this artery, this graft, to match up to where he needs to plug it in. You can still see the heart. Every time, he has a camera on his head, by the way, and that's why every time he moves his head, that's why the camera changes. So he's just sizing this up right now. This is very tiny suture. It's about half the diameter of human hair. So we really need to have magnifying glasses. If you were wearing my magnifying glasses, I mean, you would see this beautifully well. And he's just tying it down. So this is under direct vision type of bypass surgery. You may have heard of robotic surgery. I'm not crazy about the robot. There are very few surgeons in this country that are crazy about the robot for this type of surgery. Number one, it's extremely expensive. It's extremely expensive. Number two, it takes all day to do a single vessel bypass. I don't want to put my patients through 10 hours of anesthesia. I can do this operation in about 45 to 60 minutes, much safer to the patient and with much less blood loss and trauma. The robot, I think, has a place for prostatectomies, for maybe gynecologic surgery. Some surgeons are using it for mitral valve surgery, which may be the best application for it. And so what he's doing right now is sewing this graft, the internal mammary artery, directly onto the artery in front, the left anterior descending. And so this is what it would look like to me, a little bit more magnified if I was doing that. So you're basically right over my shoulder. That's perfect, Melissa. So with this being Heart Month, I think we have a responsibility to our kids, to our grandchildren, to teach them good habits. We need to teach them how to eat, how to exercise, how to take care of their bodies. Everybody in this room needs to watch their blood pressure, and the diabetics especially need to watch their blood sugar. And there are probably some people in this room that have undiagnosed blood sugar and diabetic issues right now. Every time I drive down, like First, I mean, I see a lot of business, but I also see a lot of fast food restaurants. It kind of drives me crazy. And it's here we are in the year 2012, and still heart disease is still the biggest killer in this country. While we've been here, about 5 Texans have died since we started this talk, and about 20 have had heart attacks in the 45 minutes that we've been here so far, in the state of Texas alone. And that to me is just crazy. You know, why are we smoking? Why are we not exercising 45 to 60 minutes a day? Why are we not taking care of our blood pressure, our lipid levels in our body? Why are we not going to see the doctor on a regular basis? Why do we go to restaurants and the food is so unhealthy? Why don't they have calories and fats and salt content listed on the menus of all of those? How come when a new street is paved or made in this town, why don't we have a bike lane right there? I mean, these are the things that we need to think about. You know, the second biggest killer is going to be cancer in this country. So heart disease and stroke, #1, and then #2, cancer. You know, I still see when Shelly and I bring our little guy to Denman, I see kids that are overweight. It's just crazy to me to see that. When I went to school, I grew up in Illinois, and when I went to school, we didn't have any kids that were overweight. And now, what's the rate of obesity in this country? Does anybody know? 10 years ago, it was 20%. Now, in this latest survey, it's 30%. 30%. 30% of our population has a body mass index that's more than 30%, which is just incredible to me. So those rates are going higher. The rates of heart disease are still as high as ever. Women, if they have a heart attack, do they have a better chance of surviving or less chance? Much less chance. Nobody knows why. I don't know if it's because women can put up with childbirth and women put up with men or whatever it may be. But for some reason, do not look at my wife. For some reason, women have a much higher rate of mortality if it comes to a heart attack, to stenting, to ballooning, to open heart surgery. So when I see a woman, I almost always will try to do beating heart surgery on those patients because it's so much safer. Short women have the highest risk. If you're around 5 foot, if you're thin, or if you're a little bit overweight, you're going to have a high risk. So that's why I try to use the beating heart surgery. So with it being Heart Month, and let's think of it maybe as Heart or Health Day every single day. Let's be the best role models for our children, for our grandchildren. Every day, let's think about how we can teach our kids to be exercising. I mean, I remember I would run to school every day with my friends. We would come home. We would play outside, even in the cold and snow of Illinois. We didn't have video games, and you know, we didn't really have that much at all, except for baseball bats and soccer ball and tennis rackets and football. So these are the things that I want you all to think about. And every day, when you brush your teeth and you get ready, think about, okay, when am I going to go walking for 45 minutes to an hour? Make it a social event. Join up with your friends, and instead of sitting around drinking coffee or doing something like that, go out and do some good walking. Walk together. Put on some good music. Go to the track at the high school. Go to the mall. Don't spend money, but go to the mall and just walk around. And you'll see a lot of my patients out there. Walmart is still very dangerous, especially in the parking lot. So, even though it's such a monster place, but I love to see my patients at Walmart or wherever because I love to see them walking. So think about that. Let's be the best role models we can. You know, talk to the people that run our government about, you know, making bike lanes, making more sidewalks, making it better for us to walk and to exercise and ride bikes. You know, every day we try to get our little guy out and about. I mean, our little guy, our 6-year-old, is just a stud. He's a 6-year-old, really tough kid. But he's outside every single day. And I just love to see that. I wish all of our kids are like that. You know, when you go to a restaurant, order the healthy food. And I hope nobody here has stock in McDonald's or something like that. But avoid those restaurants. Those places they're so bad for our health. The fat content, the salt content, the quality of food is not that great. And so we try to always avoid those types of places. We try to eat home as much as we can. We cook and eat very healthy at home. And I think it's very doable and very possible to do that without going to these fast food restaurants. The FDA was a creation of us in the 1960s. It was a creation of us because of the creation of the additives that we put to our foods. And that's when the FDA came about. And when you saw the creation of these fast food restaurants and all these electronic games that the kids play, they've become very sedentary. And it's a very sad state of our health in the Western world, but especially in our country.